This is looking at how weight-related teasing increases psychological complications. It's a bigger deal, even bigger in girls and guys. And if you looked at that up here, no teasing at all versus teasing by peers only. You look at teasing by families, boy, it just blows everybody away. So if people have a supportive family system, it makes a huge, huge difference if we listen to our kids about that. This is just obesity's relation to sleep deprivation. If you have problems with leptin and ghrelin, how that increases hunger, you don't feel full, then you feel bad that you eat, and then that leads to increased weight, which can lead to depression, and it's just a vicious circle. So if you can break that cycle anywhere along the way. I think I just turned it off. There we go. I'm going to bypass that. This is just a study. The research person in our practice is Dr. Chaudhry has his PhD in psychiatric genetics from McGill University in Toronto. And he actually did a study looking at obesity related to the FTO gene, the fat and something gene. What is it, the FTO?
Yeah, that you have.
The fat gene. Well, we'll call it the fat gene. But, there's a correlation for a certain segment of those folks with ADHD. Even though they're very, very busy, they tend to be obese. And there's definite reasons for that. They have a genetic predisposition for that. So we've more or less went through that. I'll get through that. There's just a bunch of laboratory testing. This has probably already been talked about, but I'm just throwing it in here. I don't know if everybody's heard about Deplin or L-methylfolate. There's at least a third of folks in the U.S. who are homozygous for a certain gene and with the bad alleles, and they have trouble converting, it's called methylfolate reductase. And if you have the bad alleles for that, you have difficulty converting folate in the periphery to brain folate. So you can give you folate all day long, like in prenatal vitamins, and it's not going to get to be the good folate you need. So there's about a third of folks who need prior replacement for that. And there's 2/3 of folks who at least are heterozygous for that. But, and then on lab testing, it's not necessarily in here, but we do a lab testing and we do a lot of vitamin D testing. And I would tell you, at least in our practice, close to 50% of folks are low on vitamin D, especially folks who don't leave the house. It's incredible. I've been amazed how many folks, 30 is the normal number, and you get down around 20 or so, you really need some significant replacement that you're not going to get over the counter. And it's just amazing how many folks are low on vitamin D. So I'm going to go through that. This is just this is a paper. There's no really good papers looking out there about if you're taking a psychiatric medication pre-bariatric surgery, how do you need to change that medicine afterwards? People believe that the absorption, especially the controlled release medications, are the ones that you need to probably change to immediate release if you can beforehand. But this is just looking on the R&Y gastric bypass pre and post and the dissolution of those. And they looked at 22 psychiatric medicines. And there were 10 medications that actually had some significance to them. Amitriptyline, most of them, 8 out of the 10, had better dissolution prior to than after surgery. And then there were a couple that actually had it better afterwards than beforehand. And then there's a gene for isoenzymes for 3A4 and 3A5. There's genetic testing for that. And those are involved in the duodenal wall. And so if you do the R and Y, you sort of take that away. So their bioavailability is going to increase afterwards. And that has to do with drugs like Fetsima in our world, Vibrad, things like that. about this a little bit. So those are just some numbers that you'll have. So here's binge eating disorder. So if you eat 1 day a week, a large amount of food in 2 hours for 12 weeks, you get that, you can have that classification. Of course, to have a disorder, it has to impair your functioning. So if you have that disorder, up to 79% of people have at least one other diagnosis, and actually almost 50% of those folks have 3 or more psychiatric diagnoses. So it's a high-risk age group. And where the other eating disorders, their age of onset is more 13 to 17, 18. The age of onset for this tends to be young adulthood. So it's a different sort of thing to look at. So we talked about immediate release, liquid crush. I would add on there, you know, there's some patches for some of the medications too. So try to stay away from some of the sustained release formulations of meds, or we crush meds too. Lithium is just in here because its level tends to go up post-surgery, and that becomes pretty important because lithium toxicity is not a pleasant thing to have. So anything that has a narrow therapeutic index like Tegretol, things like that, you want to be able to monitor both before, so you know what level the patient's at when they're doing well, and then watch it probably monthly for a few months afterwards to see how they're doing. The highest risk of malabsorption of meds are if the medication itself is intrinsically poorly absorbed, if it's highly lipophilic, or it undergoes enterohepatic circulation. And we talked about the 3A4 and 3A5. So these are actually 3A4 and 5 are very, very common isoenzymes, and they're very common on the type of pharmacogenetic testing we do. And there's more of the meds. Latuda's up there too as one of the meds that goes through that. Grapefruit juice is on there too if you. So here's the big contraindications, active substance dependence, severe depression. We're not talking about mild depression. We're talking about people with severe depression, that have significant impairment, like on the Sheehan disability scale. And depression is pretty easy to follow. I didn't throw it up here, but there's the patient health questionnaire, PHQ-9. The patient does it. It takes them about 2 or 3 minutes to fill out. And if they're hitting probably above about a 15, 14, 15, they're somebody to really start looking at, because you're hitting moderate to severe depression in those folks. And it doesn't take the clinic's time to do it other than looking at. And it's a great tool to follow patients on. There's a few patients who I don't know if they have, it's not that they have good insight, but they hate to say how depressed they really are. So they'll come back and they'll score like an 8, which is a little mild, and they're sitting there crying the whole time in front of you. So you still have to have a conversation with them, but it's a nice screener.